Good evening and welcome. I'm Vanessa Hoffman, Program Coordinator for Research and Education at the Bladder Cancer Advocacy Network, Beacon. Tonight we present Signs, Symptoms, and Tests, the first webinar in our winter series on diagnosing bladder cancer. I'd like to do some quick housekeeping before we start. Take a look at the left side of the screen for instructions on how to listen in on the webinar. There's information about the WebEx tech support if you're having trouble with that. In terms of asking questions, please type them in the Q&A box on the right side of your screen. You can type them in as you think of them, but we'll be answering questions at the end of the webinar, as many as we have time for. The webinar will be recorded and should be available on the Beacon website within the next 2 weeks. I would like to introduce our distinguished speaker now. Dr. Matthew Nielsen is Assistant Professor of Surgery and Urology at the UNC Lineberger Comprehensive Cancer Center. He will be speaking about the risk factors for bladder cancer, signs and symptoms of the disease, and the many tests that are used in diagnosing bladder cancer. He will speak for approximately 20 minutes, and then we'll be able to answer questions for about 15 minutes. I will read out the questions, and you're welcome to type them in. So without further ado, let's get started.
Hi, can you hear me okay?
Yep.
All right. Well, thanks very much for that nice introduction, Vanessa. It's a real honor to be a part of this program. And as Vanessa said, I'm going to run through some slides, and then hopefully we'll have some time for questions at the end. So as you think of questions, if you can type them in, then we'll get to as many of them as we can. So let me see here. So first of all, some general talking points about bladder cancer. Bladder cancer, as we know, is a common and costly disease. It has been called the elephant in the room because it's so common, but yet so poorly understood and has such limited public awareness that we believe there's a lot of work to be done. Tonight we're going to be talking about signs and symptoms of the disease and some brief points about the multimodal diagnosis and staging. Additional content will be presented at the webinar next week by Trinity Bivilacqua and Donna Hansel in more detail about staging. One of the interesting things about bladder cancer is that there really are complex and variable risks. It's not a monolithic disease with very different risks associated with stage and grade. And survivorship for bladder cancer is a complex topic a bit beyond the scope of what we're going to talk about tonight. But Beacon has a lot of great resources for that. So bladder cancer currently has about 71,000 new cases this year in the United States, about 14,000 deaths per year. It's the 4th most common cancer in men, the 11th most common in women. It's typically diagnosed in adults in the 5th to 8th decade, and globally it's incredibly common with over 350,000 cases. It's actually the most common genitourinary cancer in China. And non-muscle invasive or superficial disease comprises the majority of new cases, and is particularly in that group, there's the noteworthy statistic that bladder cancer has the highest recurrence rate of any cancer, and so there's a substantial burden associated with the disease. Despite that, there's comparatively poor research funding. The economic burdens of bladder cancer are significant, and one number that I think is particularly noteworthy is that bladder cancer has the highest per-patient treatment costs from diagnosis to death. Recent cost increases are substantial, and despite all this, there's still limited public awareness and research funding. And these are just some figures that Beacon has put together, noting the declining budget for bladder cancer research from the NIH, and particularly compared to other disease sites, we believe there's a lot of room for improvement in terms of increasing bladder cancer research. So bladder cancer is a common disease with significant burden of mortality, has significant costs, the management is complex, the research funding is poor. And for all these reasons, we believe there's potential for improved prevention, early detection, and treatment strategies which could be supported by further research. And a lot of this is driven by increased awareness, and this is a big part of the Beacon mission. What a lot of people listening to this webinar tonight are probably people who can help us out with that. So my topic tonight is diagnosing bladder cancer, signs, symptoms, and tests. I'll briefly touch on risk factors for bladder cancer, signs and symptoms of the disease, some of the tests that are used to diagnose bladder cancer, and what some specific factors about these different tests include. So as far as risk factors go, the most significant risk factor for bladder cancer is age. And as this cartoon shows, it's one of those cruel ironies of life that the longer you live, the more medical problems that you are at risk for, and this is certainly true for bladder cancer. The average age of diagnosis is 74 years. The highest rates per 100,000 population are actually in 80 to 84-year-olds, and as the population ages over the next few decades, bladder cancer is going to become an increasingly common problem. Other than age, the most significant modifiable risk factor for bladder cancer is cigarette smoking. There's approximately a threefold increased risk in current smokers, and interestingly, a reduction in the risk after people quit smoking. And so this is an important piece of awareness, because this is not just lung cancer is not the only smoking-related disease, and bladder cancer actually has a significant benefit from smoking cessation. The population attributable risk for smoking is nearly 50% of the risk in men and about a quarter of the risk in women. So smoking cessation is an important part of bladder cancer risk reduction, and this is actually something that is being pursued by one of BCAN's fellows, Jeff Bassett, at Vanderbilt, who presented his work last year at the think tank. Family history is actually not as significant of a risk factor for bladder cancer in the classic sense in terms of a disease that runs in families by genes, but there can be a secondary smoke exposure can be a sort of indirect family history for bladder cancer. And then there's also some occupational environmental risks associated with smoke exposure, and for instance, flight attendants who worked prior to smoking being banned on airlines rank among occupations that have an occupational risk of secondary smoke exposure. So again, some more data on the risk associated with smoking. Current smokers have a higher risk, about a threefold risk. Former smokers have about a twofold risk compared to never smokers. And again, about half of male cases are attributable to smoking, with a slightly lower proportion in females. When people quit smoking, there's an immediate, within 5 years of quitting, 30 to 50% decrease in bladder cancer risk. Other risk factors include occupational exposures, certain chemicals in different occupations, particularly aromatic amines and nitrosamines, which are involved in some chemical occupations, and diesel exhaust. Arsenic is an environmental risk factor, sometimes found in well water. This is a particularly big problem in Taiwan and also in certain parts of the United States, particularly the Northeast United States, and there are other hot spots of arsenic where that can be a potential environmental risk factor for bladder cancer. Chronic cystitis from schistosomiasis is the most common cause of bladder cancer in parts of the world where schistosomiasis is endemic, such as the Nile River Valley in Egypt. And cyclophosphamide or cytoxan chemotherapy also is a risk factor for bladder cancer. This is a kind of chemotherapy that's used in certain kinds of hematologic malignancies and others. There's conflicting data about the risk associated with pelvic radiation therapy, although a number of studies have suggested that patients who've had pelvic radiation for prostate or rectal cancer or GYN malignancies may have a slightly higher risk of bladder cancer. And some recent data suggest that patients with deficiencies in vitamin D may actually have a higher risk of bladder cancer than those with sufficient levels of vitamin D. There's also conflicting evidence about dietary risk factors, but some studies suggesting low-fruit, high-fat diets may have a higher risk for bladder cancer. So in terms of signs and symptoms, the most common presentation of bladder cancer is hematuria, or blood in the urine. And this is not a disease for which current recommendations include population-based screening, such as is the case for colorectal cancer or other common cancers. But as a practical matter, many patients do get their urine checked going to the doctor, so there's some indirect population-based screening that goes on. When patients have gross hematuria or visible hematuria to the naked eye, the risk of bladder cancer in that setting is much higher. About 13 to 35% of patients presenting with gross hematuria there's about a 13 to 35% risk of bladder cancer. For microscopic hematuria or hematuria, blood in the urine that is not visible to the naked eye, the risk is lower but still present. one of the important factors to consider in terms of the risk associated with blood in the urine is, number one, that it is often painless, and number two, that it can be intermittent. And this is one thing that can potentially lead to delays in diagnosis, because a patient can sometimes have blood in their urine and then it goes away, and they may think that they or their physicians may think that that doesn't warrant additional evaluation. But in general, any episode of hematuria in an adult warrants a consideration of further evaluation. So just because it goes away, that doesn't mean it's okay. Higher risk patients with blood in their urine who certainly warrant more consideration of evaluation include those over 40 years old, anyone who's a current or former smoker, anyone with occupational exposures that we talked about earlier, obviously a prior history of bladder cancer, and patients with recurrent urinary tract infections also warrant consideration of evaluation. An additional symptom that can sometimes point to a potential bladder cancer diagnosis is what's called irritative urinary symptoms, and these include urgency, frequency, dysuria, or pain with urination, and microscopic hematuria. Those kinds of symptoms also should alert a patient or their physician to consider evaluation. In terms of the current state of affairs with the evaluation of hematuria, I think it's safe to say there's probably some room for improvement. In general, both in the general population and as well as primary care physicians, there's somewhat of a lack of awareness and evidence of variations in care and potentially delayed referral for evaluation. In a survey study of primary care physicians, about 3/4 reported that they referred patients for evaluation with gross hematuria. About a third reported that they routinely referred patients for evaluation with microscopic hematuria, and this was a study done by Yair Lotan, who's on the Beacon Scientific Advisory Board. Multiple additional studies looking at actual care received by patients demonstrate that there's substantial inconsistencies and variation in care, and one of these was done by Cheryl Lee, another Beacon SAB member. To address this, there are a number of efforts underway. Beacon has started to actively pursue some programs to increase public awareness about hematuria, and the American Urological Association is currently partnering with a number of primary care professional societies to try to disseminate guidelines and increase awareness among primary care physicians. There's also some interesting new biomarkers that might help to identify patients at higher risk with microscopic hematuria to potentially target evaluation even more precisely. So the evaluation of hematuria, or blood in the urine, starts out with urinalysis. In the case of microscopic hematuria, a dipstick urinalysis, which is a common test performed in the physician office, doesn't necessarily diagnose hematuria. It may suggest it, but a microscopic evaluation of the urine is actually required. A microscopic urinalysis is required to diagnose actual red blood cells. A urine culture can be performed to exclude a urinary tract infection, and a urinary cytology may be obtained, and that's actually a microscopic examination of cells in the urine. This is just a representative picture. This test is best for detecting high-grade disease, and when this test is positive, that has a very high predictive ability to indicate the presence of bladder cancer. It is often negative in low-grade disease, but in high-grade disease, that's a situation where the cytology is a particularly useful test. The additional steps in the hematuria evaluation include some imaging, typically these days performed with a CAT scan, historically with an IVP, and this provides imaging of the kidneys and upper urinary tract. Because the cystoscopy, the endoscopic examination of the lower urinary tract and the bladder, does not provide a picture of the upper part of the urinary tract as another potential source of blood in the urine. Cystoscopy is typically performed these days with a flexible cystoscope in the office, and interestingly, a couple of different studies have suggested that this is less burdensome to the patient when they actually watch the screen, so the distraction of just watching what's going on can sometimes make this a little bit easier to get through. And if something is detected on this exam in the office, then a patient is typically taken to the operating room under anesthesia for either a bladder biopsy or a transurethral resection of bladder tumor, what's often abbreviated as TURBT. A number of new directions in detection include a variety of urine-based markers. Several of them are currently FDA approved. The ultimate role of these in current practice is not clearly defined. A variety of strategies have been suggested, and currently 4 of them are FDA approved. A number of other urinary markers are at the investigational stage and may eventually become approved. There's also some new technologies to enhance cystoscopy. Fluorescent cystoscopy is a technology that was approved for use in the U.S. in 2009. It's been used in Europe for several years prior to that. And narrowband imaging is another technology that's demonstrated some promise in this setting. Confocal laser microscopy is an investigational study that may one day have a role in the enhancement of cystoscopy. So the urine-based markers include FISH, NMP22, BTA or bladder tumor antigen, and immunocyte. Those are the FDA-approved tests. The studies examining the impact of these tests have shown mixed results in terms of clear benefits with regard to patient outcomes. One concern about the use of these tests is that when one of these tests is positive and the standard tests of cystoscopy and cytology and imaging are negative, sometimes that can lead to a lot of burdensome workup that may or may not ultimately benefit the patient. So the role of these is at this point somewhat unclear, and they're not currently recommended in routine use in any of the clinical practice guidelines. These are just some representative pictures of some of the different tests. The NMP22 test is like a pregnancy test. It's basically a few drops of urine on a little plastic strip, and that can actually be used with by the patient themselves at home. So some pictures about some of the new cystoscopy technologies. Hexvix, or in the United States it's marketed as Cysview, is the blue light cystoscopy or the fluorescent cystoscopy. And with this, blue dye is instilled into the bladder prior to the cystoscopy procedure, and the camera can toggle back and forth between the conventional white light and blue light to highlight the fluorescence. This is currently only approved for use at the time of tumor resection, not at the time of initial diagnostic cystoscopy or surveillance cystoscopy, but it does suggest the ability to potentially detect disease with a little bit more precision. Narrowband imaging is another technology that has the potential to more clearly delineate irregular areas in the bladder lining. When a tumor is diagnosed, the key factors of grade and stage help to put people in different buckets of risk. Donna Hansel and Trinity Bivalacqua next week are going to talk about this in more detail, but grade basically is different microscopic appearances, and low-grade and high-grade disease actually also have very different biology underlying their clinical behavior. Both types of bladder cancer have high recurrence rates, but the progression rates, or the progression of superficial disease to muscle-invasive disease, is much higher with higher stage or higher grade disease. And among bladder cancer cases, there's very big differences between low-grade and high-grade disease in terms of subsequent risk. So this slide just breaks down the risk of progression by grade and clearly shows that among the high-grade cases, the risk of progression, and progression is defined as recurrence of a muscle-invasive tumor, is much higher for patients who initially have high-grade disease. So for patients with non-muscle invasive disease, and this represents about 3/4 of new cases, there's a consideration of restaging in the case of high-grade disease. These patients are typically recommended to have regular follow-up cystoscopies. And again, there's a variable risk of recurrence and progression, primarily based on grade. Intravesical therapy is treatment that's delivered into the bladder. This can be given at the time of resection, following resection, or in the adjuvant setting for multiple weekly courses after the resection is done, and this will be again talked about more in detail next week. Muscle-invasive disease represents about 1/4 of new cases. There's a variable risk of superficial cases progress to muscle-invasive disease, and this is a setting where we talk about radical options, radical surgery, potential chemoradiotherapy, and potentially chemotherapy. And this results in the use of different urinary diversions and potentially chemotherapy. And in this situation, the tumor that we see in the bladder is really the tip of the iceberg, and so we end up recommending a much more aggressive treatment. This is because muscle-invasive disease has a more lethal potential if not treated appropriately, and for reasons that are unclear, there appears to be fairly significant variability in treatment in the U.S. In Medicare patients, about 20% receive radical cystectomy, and this is work done by John Gore, a member of the BCAN working group. And so some take-home points from all of this. I think one of BCAN's big added values in the last 7 years, 8 years that it's been around has really helped drive home that people dealing with the disease are not alone. And in terms of making good decisions, this is part of Beacon's mission of education and helping people know more about the disease and the options. The internet provides a lot of resources, and the Beacon website has a lot of great information. They also help support the development of a lot of support groups all over the country. They can also provide some information in terms of provider selection for second opinions, and give you some points to ask when you go to meet with your provider. And all of this helps people to become more involved in their own rescue. And so I'd just like to thank Beacon for giving me this opportunity. It's amazing to see how much this field has changed in the last several years since Beacon has come on the scene. Diane and John Qualley started this all up in 2000 when John was diagnosed. There was really limited information available, but now, thanks to the work of Beacon, there's a much richer support community out there, and it's great to be a part of this. So thanks very much. I'd be happy to take some questions.
All right, thank you, everyone. Thank you so much, Matt, for a wonderful presentation. I'm Dr. Nielsen. Now we'll have time for some questions and answers. Please, again, type your questions into that Q&A box on the right side of your screen. I'll be reading them out. So first question, what is the likelihood that a low-grade bladder tumor will progress to a high-grade bladder tumor, and is there anything a patient can do to stop that from happening?
It's a great question. So I think that goes back to the slide that I showed with the table earlier. The risk of progression for bladder cancer is very variable. For patients who have non-muscle invasive disease, the question of progression implies that someone with non-muscle invasive disease progressing to muscle invasive disease is the way that I sort of read that question. And in general, patients with low-grade tumors historically have relatively lower risks of progressing to a high-grade muscle invasive tumor. The risks that have been published for that are in the range of 1 to 5% at 5 years. In terms of progressing to a high-grade tumor of any stage, including a non-muscle invasive high-grade tumor, the risks of that are probably more in the 10 to 15% range, and that varies based on the patient factors in terms of the size of the initial tumor, the number of tumors that are there, whether there's recurrence. Patients who have frequently recurrent low-grade tumors actually have a higher risk of recurring with a high-grade tumor or potentially even a muscle-invasive tumor. But in general, the risk for low-grade tumors is recurrence of low-grade tumors.
All right, thanks so much. Next question is, what does carcinoma in situ mean?
Carcinoma in situ implies a flat, high-grade tumor that does not invade the lamina propria, or the layer of tissue immediately below the lining. So all of the bladder carcinomas, the most common type of bladder cancer, arise from the lining initially. And some of these can be papillary, and that means they sort of look like a cauliflower, or a little growth like coral coming out of the bladder wall. But carcinoma in situ, by definition, is flat, and also by definition is high grade. So whereas papillary tumors can be low grade or high grade, carcinoma in situ by definition is high grade. And despite the word in situ in some other contexts being associated with lower risk, carcinoma in situ in the setting of bladder cancer actually is associated with somewhat higher risk. And so in that situation, we generally treat them more aggressively, and when people have frequently recurrent carcinoma in situ, they often are recommended to consider cystectomy. And so the T-type given carcinoma in situ is considered TIS, if that's the only tumor present, to get to the second part of that question.
Okay, great. And then I guess going back for the next question, I believe someone had asked, what does infiltration high-grade urothelial carcinoma with extensive glandular differentiation in areas of suspicious for lymphovascular invasion mean?
So that's a good question. High-grade urothelial carcinoma sort of gives us the answer to the question of whether it's high-grade or low-grade, and again, that's an important distinction. With the infiltration adjective implies that it is invasive, at least to some degree. And usually the pathologist will say on the pathology report whether it's infiltrating into the lamina propria or the level immediately below the lining, which would be a stage T1, or whether it's infiltrating into the muscularis propria or the muscle wall, which would be a stage T2. The glandular differentiation is something that's sometimes observed. The traditional differentiation that the pathologists describe is urothelial carcinoma, but that can sometimes create patterns that look like glands and sometimes can create patterns that look like skin or squamous histology. And whenever there is variant histology or something varying from the conventional urothelial carcinoma pattern, that's usually commented on by the pathologist, and that often is associated with a higher grade or more aggressive disease. The finding of lymphovascular invasion in general is something that we get a little bit more concerned about. That suggests some more aggressive behavior. And in that situation, sometimes people who have stage T1 tumors with lymphovascular invasion are counseled to consider more aggressive treatment options than patients otherwise with non-muscle invasive disease.
Okay, great. For the next question, I've completed the 6 weekly BCG treatments, and now I'm waiting for my 6-week follow-up. What should I expect during this follow-up exam? What questions should I ask? I'll just say briefly that we're going to be having future webinars that are going to talk about BCG and other treatments, and that Beacon does have patient tip sheets that specifically go over questions to ask. I don't know, Dr. Nielsen, if you want to comment briefly on that.
Yeah, sure. So usually after completing the 6 weekly BCG treatments, we often like to wait a number of weeks after completing those treatments to let the inflammation that is characteristically associated with BCG to recede somewhat, so the picture that we get when we look back in the bladder can be a relatively clearer picture. And I don't think there's anything written in stone about how long that delay is, but commonly it's 4 to 6 weeks after completing the 6-week BCG. And what is typically done at that visit is to perform a cystoscopy. And so with 6 weeks of treatment plus 4 to 6 weeks of post-treatment settling, that usually ends up being about 3 months after the initial tumor resection. And that usually includes a cystoscopy and a cytology. There is variability in terms of whether surgeons will go ahead and do repeat biopsies in that setting. That's something that usually is driven by the surgeon's experience and the patient's specific factors, but the 2 parts of that evaluation that are the most commonly done, and I think probably the most standardly done, are cystoscopy and cytology at the time of that visit. And in terms of questions to ask, I guess one question that I would think of potentially asking is whether after completing that 6-week, what we call induction course of BCG, whether the physician recommends consideration of maintenance BCG, which is basically a smaller number of doses over a longer period of time as sort of a booster to the initial BCG, as a number of clinical trials have suggested that provides even more benefit than BCG alone, induction BCG alone.
Okay, great. For the next question, how accurate is cytology? What % are false positives?
That's a great question. Cytology is, and so these words are all kind of loaded words in the diagnostic test world. And accuracy of cytology can be thought of in terms of true positives, true negatives, false positives, and false negatives. And the thing that is really good about cytology is what we call the specificity. And that means when you get a positive test, how likely is that to be a true positive test rather than a false positive test. And that's probably the biggest strength of cytology, is that when cytology is positive, it is rarely a false positive test when cytology clearly shows malignant cells. Sometimes the cytology can come back with a result that is atypical, not quite malignant, and that's a little bit more of a gray area. But when a cytology is positive, it's rarely a false positive. in low-grade tumors, the cytology can be negative because the cytology is best at detecting high-grade cells. Those are the type of cells that are shedded more from tumors and are floating around in the urine more, able to be detected by cytology more. And so there can be more false negatives with cytology, but particularly in the setting of high-grade disease, the true positive and true negative rate is better than for a lot of the other urine-based markers. One of the concerns about some of the other urine-based markers that I touched briefly on is that many more of them have false positives where the test can be positive, but the standard diagnostic test of cystoscopy and cytology may be negative, and that can create some real quandaries for patients and their doctors to figure out what to do with that. And so partly for that reason, those tests are not recommended for routine uniform use and really should be used more in sort of select settings.
Okay. And for the next question, can working at a dry cleaners and doing dry cleaning work for years in college cause bladder cancer?
Well, that's a good question. Dry cleaning is, I believe, a few different studies have suggested that people who work in that industry, particularly in certain eras when certain kinds of chemicals were used, may have a slightly higher risk of bladder cancer. I think it depends on when and for how long someone was working in that setting and what sorts of chemicals they were exposed to. But I do believe that the dry cleaning industry is one that did come up in some of the studies of occupational exposures that may have a slightly elevated risk of bladder cancer.
Okay, great, thank you. For the next question, any comments on how the new federal health care law will affect care and diagnosis techniques currently used in diagnosing bladder cancer?
It's a good question. I think at this point it's really too early to say what the impact of health reform is going to be on bladder cancer, really any other disease. I think there's a lot of anxiety on the part of patients and physicians and everyone about what the future holds as far as that goes. I think at this point it's probably fear of the unknown because I don't think anything really specific has come out. I do think that maybe not even so much as a product of the new federal health law, but just a product of the overall healthcare costs in the U.S., that we will be under increasing pressure to justify the value of different things that we do. And so I think there will probably be more scrutiny about high-cost tests and procedures and treatments of uncertain value, but I think at this point in time it's probably premature to really make any specific thoughts on what exactly the impact of the new federal health law will be for diagnosing bladder cancer.
All right, well, thank you for taking that one on. Question, are there things that a patient should watch for between cystoscopies?
It's a good question. It's not uncommon right after getting a cystoscopy to have fairly bothersome urinary symptoms just from having the instrument put in the urinary tract. Also not uncommon to have a small amount of blood in the urine. But usually the cystoscopies are recommended to be performed at relatively regular intervals, particularly during the period of time when someone's at the highest risk of recurrence. And so I think that the best thing to watch for is just to make sure that that follow-up cystoscopy is scheduled. And I can't think of any real specific other symptoms. One thing that might warrant consideration is if those irritative urinary symptoms last more than a day or two after the procedure, you might want to get a urine checked for an infection with a urine culture, just to make sure that despite taking an antibiotic around the time of the procedure, sometimes there can be a urinary tract infection can result from that invasive test.
Okay. For the next question, fluorescence after a TURBT with a low-grade tumor, is this used very often?
Well, fluorescence cystoscopy is, I think, not used very often in the U.S. now, just because a lot of physicians and hospitals have not yet started using it. It's a fairly significant investment for a practice or a hospital to get that technology, and so I think the biggest variable right now is just whether it's available, period. But at a place where it is being used, I think there's sort of an evolution in how it's being used. I think in general, it's probably most useful for detecting higher grade disease because the studies that have looked at that have suggested that the ability of the fluorescence cystoscopy to pick up CIS or carcinoma in situ may be one of the particular strengths of that. So for patients with low-grade tumors, in the right context, it may be the absolutely appropriate thing to use. But I think at this point in time, it's FDA approved. It's a current accepted treatment, but I don't think at this point it's the standard of care in the U.S. just because the availability is still relatively limited.
Okay, great. For the next question, what does it mean when you say that molecular testing has not been approved, and what governing body would approve that type of test?
That's a good question. So when I talked about tests that are approved, diagnostic tests have to be approved by the Food and Drug Administration. And so there are a lot of investigational markers or tests that have been studied in research settings that have some degree of evidence of potentially being able to detect bladder cancer, but haven't gone through the process, typically in clinical trials, proving that they work to get approval by the Food and Drug Administration to be used in clinical care. And so right now there's 4 urine-based markers that are approved by the FDA, and then the fluorescence cystoscopy relies on a drug or a dye, basically, that has to be put into the bladder, and that technology was also approved by the FDA in 2009. And so for any sort of test to be used in a patient to really guide the way that they're treated and get reimbursed by Medicare also, it has to be approved by the Food and Drug Administration, and that is trying to regulate making sure that things that are used in patients are effective and safe, and it puts barriers in place, but I think the argument is that those barriers are there to try to help people get good care.
Okay, great. For the next question, what affects the rate at which bladder cancer can recur?
So that's a good question. I think the answer to that question varies based on the context that you're talking about. So in the setting of non-muscle invasive or superficial bladder cancer, which again is the majority of new cases, in that setting when we talk about recurrence, we're usually talking about a new tumor in the bladder that is another non-muscle invasive or superficial tumor. And the recurrence rates, again, for bladder cancer, particularly in that setting, in the superficial setting, are really the highest of any cancer type. Among patients who have low-grade tumors, they can still have relatively high recurrence rates. Those recurrences are typically low-grade tumors, which are almost always non-invasive and relatively low risk. Among patients with higher-grade tumors, they have higher recurrence rates in terms of subsequent occurrences of non-muscle invasive or superficial tumors. They also have higher rates of progression, which is recurrence of a muscle invasive tumor. And then when we talk about patients who have higher risk disease like muscle invasive disease or metastatic disease, the recurrence rates in that setting are often more metastatic recurrences outside the bladder. And that is a function of the tumor biology. In the case of muscle-invasive disease, the stage of presentation, whether lymph nodes were involved, whether chemotherapy was given, and a variety of factors affect recurrences in that setting. And so recurrences in the setting of superficial disease, we're usually talking about local non-muscle invasive recurrences, and then in the setting of advanced or metastatic disease, it's sort of a different ballgame. But fundamentally is a function of the biology and the kind of treatment that a patient gets are the two probably biggest factors that affect that.
Okay, and it looks like we only have time for one more question. So what research is being done on preventing bladder cancer? How current is the research on the risks? And is there any known correlation of risks with exposure to secondhand smoke?
Okay, so a couple-part question. So research on prevention for bladder cancer, I think right now probably the best way to prevent bladder cancer is to increase smoking cessation, because it's probably the single biggest modifiable risk factor for bladder cancer. And so there are some research studies being done looking at ways of using the risk of bladder cancer or other smoking-related cancers as more of a motivation for people to quit smoking. It probably is the single most important thing that someone could do for their health in general. And in terms of bladder cancer risk factors, it's probably the single biggest modifiable risk factor. You can't really make yourself any younger, and for people who've had occupational exposures in the past, it's hard to sort of undo those. There's actually some really interesting research that came out a few months ago looking at data from a large study of bladder cancer patients in Spain that was published in the Journal of the National Cancer Institute that suggested that the risk of bladder cancer among patients who had low vitamin D was higher than those who had normal levels of vitamin D. And so that, if that proves to be true, could potentially represent an opportunity for prevention. And then there's also a sort of complicated world of talking about prevention for cancer, but there's primary prevention, which I think is what most people think about when they think of prevention, trying to take aspirin to prevent having a heart attack, that kind of thing. And then there's secondary prevention, where someone who already has a diagnosis is trying to keep it from becoming worse or progressing in some way. And that probably is the space where there would be the most room for work in bladder cancer. And in that setting also, I think a case can be made for smoking cessation as a way of secondary prevention, because there's some evidence to suggest that people who quit smoking actually see a reduction in their risk of bladder cancer recurrence. There's also some studies coming out now looking at some different dietary modifications, increasing vegetable consumption and things like that, that might potentially reduce the risk of recurrences among people who already have a diagnosis of bladder cancer. And so I think there's actually a lot of sort of interesting things going on, but the short answer to the question would be probably the single biggest place to make some gains in terms of prevention for bladder cancer has to do with more smoking cessation. And in general, in the U.S., we have seen the smoking rates go down pretty dramatically in the last few decades, but there's still room for improvement. In other parts of the world, like in China in particular, there's a huge smoking epidemic, and worldwide there's probably a lot more work to be done even outside the U.S. And so what was the second part of the question, Vanessa? I'm sorry.
The second part was asking about secondhand smoke.
Yeah, so secondhand smoke, I think it's not been as well studied because in general bladder cancer is a relatively rarer disease compared to like lung cancer, for instance. But there has been some suggestion that that people who have significant exposures to secondhand smoke probably have an increased risk of bladder cancer also, and this would apply to people who live with someone who smokes, or people who work someplace where there's a lot of smoke, people who work in a bar, people who were flight attendants back in the era when smoking was still allowed on airlines. And so I think it's not as clearly demonstrated for bladder cancer as it is for some other smoking-related diseases, but I think there's some evidence to support that there's correlation of risk with the exposure of secondhand smoke.
Okay. Well, thank you very much, Dr. Nielsen. We really appreciate your time and presentation. Sorry we weren't able to get to all of the questions tonight, but this webinar is being recorded. Will be available on the Beacon website as well as the slides. And please tune in next week for the second part of this webinar series, going in more deeply in terms of stages, grades, and pathology. Thank you, everyone, and have a great night.